a 2 centimeter renal stone, PCNL may be the way to go, but you know, as you know, there are different sizes, not of the stone, but of the PCNL. Now, this would be the 2 centimeter typical renal pelvis stone we are probably talking about today. And if you look at the EAU guidelines, then if you look on the left side, if you have a stone up to 2 centimeter, you can even do shockwave, but you should do endourology. Now, endourology can be both. It can be PCNL or it can be flexible ureteroscopy. Now, on the right side, you see that the lower pole is a slightly different story. As we all know, we have to take special considerations of the so-called favorable factors, which is a narrow calyx neck, a sharp angle, as you see here on the picture, and a long calyx neck. Now, what are the indications for PCNL in general? Now, calyx or renal pelvic stones from 1.5 centimeter upwards. Now, this, of course, can vary with your personal likings. Some people say 2 centimeter. My personal cutoff is 1.5 centimeter. That doesn't mean that URS can't be done for those stones. It's simply that there is a bit of a gray zone, and that's why we are debating today. Now, Stackhorn stones, I think nobody really would like to do that with flexible ureteroscopy. Calyceal diverticulum stones are a special talk, which would be too much today. But as you know, they can be approached from outside, from inside with ureteroscopy or PCNL. And then the lower pole stones with the favorable or unfavorable factors, depending on where you come from. Now my slides are not moving, just a moment. Okay. Yeah. Now, why would one do a standard PCNL? Standard PCNL is usually with the sheath 30 or 28 French. Well, certainly if it's an easily accessible location, if you're good at it, you will have a very fast access and dilatation. You only need a very few fragments, maybe break it in 2 or 3 fragments and then take them out. And the operating time in a quick case can be even less than 30 minutes if you do it in the supine position and there is no need to reposition the patient. And then, you know, of course, a few years ago came the concept of miniaturization of PCNL. In 2015, there was an EAU survey done by ULIS, and 87% of endourologists were doing PCNL. 58% at that time were doing mini PCNL. 23% and 28% respectively were doing ultra mini and micro PCNL. So when these people were then asked, what would you do for a stone smaller than 2 centimeter in PCNL, 100% agree that you can use any form of miniaturized PCNL, be it mini PCNL, ultra mini, or micro PCNL. Now, if the stone is bigger than 2 centimeter, only 50% would actually use any of these miniaturized nephrolithotomies. Now, what's the idea behind miniaturization of PCNL? The idea is that your tract size reduces over proportionally with the size of the instrument. So meaning that if you look from the left to the right, if you halve the diameter of your track of your sheath from 26 to 12 French, you actually reduce the tissue damage by factor 5. So that's over proportional. Now, very early in the piece, already in 2001, when only a very few people were doing mini PCNL, Lama had already shown very nicely that, at least if you look at the Clavian grade 1 and 2 complications, and we all hope we don't have more than that, that mini PCNL has a clear advantage in having less complications than the full-flesh PCNL. So why not only do flexible URS for stones up to 2 centimeter? Well, if you look at the operating time, then this is somewhat shorter with mini PCNL. The redo rate is certainly shorter with mini PCNL, and the stone-free rate is slightly higher with mini PCNL than flexible ureteroscopy. So typical stones, say 17 by 17 millimeters or 300 square millimeters, you can see here that although the stone-free rates are similarly good, I would say, but the PCNL rate is still significantly higher than the one for flexible ureteroscopy, namely 95% for PCNL as compared to 87% for flexible ureteroscopy. Now, if the stones become even bigger, then the stone-free rate goes dramatically down for flexible ureteroscopy, namely to 54% on average. With the second attempt, it can then go up to the previous 87 or 86%, but you need 2 operations for that. And this is very nicely shown here. If you go in the range over 2 centimeters, the factor of reoperation is 1.46, which is basically 1.5. And that tells us that every second patient will need a second operation with flexible ureteroscopy. Now, if we compare mini-PERC and flexible ureteroscopy, then we can see that the operating time in this paper was significantly less. The stone-free rate was somewhat higher, 92 versus 84%, but not surprisingly, there were 2 bleeders in the PCNL category, which doesn't apply for the flexible ureteroscopy. So mini PCNL had a better stone-free rate than ureteroscopy, but hospital stay was longer and there were more intraoperative complications. On the other hand, flexible ureteroscopy had a longer operating time and also, what wasn't shown in the table, a higher incidence of postoperative fever, which is actually the most common, if not significant, complication of endourology in the Clavian classification. Now, this paper of 2015 compared mini PCNL versus flexible ureteroscopy on 70 patients. The stones were all bigger than 1 centimeter, and the stone-free rate for mini PCNL was 86%, for flexible was 97%. So flexible ureteroscopy was clearly the winner here, but, and that may be surprising, but that's what's written in that paper, there was significantly more pain and need for analgesics after flexible ureteroscopy than it was for mini PCNL. Now, Schönthaler in Germany looked at ultra mini PCNL and compared that with flexible ureteroscopy, and he found that in all the parameters of clinical outcome, they were more or less equal. But the hospital time and the operating time was higher in mini PCNL. So this is somewhat contrary to what I've said before in the other paper. Now, in the German system, the costs are significantly lower for ultra mini PCNL though. So the cost for a flexible ureteroscopy is 77% higher than it is for ultra mini PCNL. That may, of course, vary from health system to health system. That may vary from country to country. And also, please keep in mind that these papers are from 2015, so they're 4 to 5 years old, and we didn't have disposable instruments at that time, and that they're coming more and more, and that, of course, may change the picture, especially what costs are concerned. Now, this is a meta-analysis, PCNL versus flexible ureteroscopy. And it was concluded that PCNL has a better stone-free rate, however, has more complications, more blood loss, and more hospital time. This is what we normally discuss and expect. Now, if they compare flexible ureteroscopy with mini PCNL, then RIAS has a better stone-free rate. So you see that the data, depending on the papers you look at, they vary strongly, and sometimes they're in favor of flexible ureteroscopy, sometimes they are not, and the parameters, they're changing. So these authors, they then concluded that flexible ureteroscopy should be the first choice over mini PCNL, which has a higher morbidity and lower efficiency. However, if flexible scopes are not available, and that applies, of course, still in many countries, then PCNL is the first choice. They say that PCNL has a better efficiency than mini PCNL in their hands. So what does all that tell us? I mean, what I've told you now is that if you see the literature, you look at the papers, one paper says this, the other paper says that, right? And the information is kind of going to one side and to the other side. So we don't really know which one is better, right? And maybe after this debate, we wouldn't know either. Clear is that flexible ureteroscopy from the beginning started with very small and ureter stones and is dealing with ever larger stones. And mini PCNL, and PCNL for that matter, having been miniaturized, is dealing with ever smaller stones. So at the end, of course, both mini PCNL and URS, Hisham and myself, we will fight for the same stones. So why then do mini PCNL at all? Well, it may come down to costs. Mini, micro, and ultra PCNL instruments are less fragile. They're made from metal, right? So if you can afford disposable instruments for flexible ureteroscopy, that's fine because you throw them away. But if you can't, then you have a $15,000 instrument at your hands with a limited durability, and that is an important cost factor. For PCNL, you need less disposables. You don't need generally, you need less disposables, especially for the mini PCNLs, because they come with their own sheets and their own dilators. You need less technical infrastructure, shorter hospital stay. You can do completely tubeless if you want to. There's a low redo rate, as I have shown before. And of course, you can remove all the fragments, at least if you go down to ultra mini PCNL, not with the micro PCNL, which you may not be able to do with flexible ureteroscopy.